Welcome to this podcast from Neurogastroenterology and Motility. It publishes original research and topical reviews on basic and clinical aspects of gastrointestinal sensation and motility, as well as brain-gut interactions.
So welcome everyone to this month's podcast on Neurogastroenterology and Motility. My name's Adam Farmer and I'm a consultant gastroenterologist at the Wingate Institute in London. This month it's my pleasure to welcome Dr. Denise Strijbos from the Nutrim School of Nutrition and Translational Research in Metabolism from Maastricht in the Netherlands. So Denise, many thanks for joining us on the podcast this month. Congratulations to you and your co-authors on your really interesting paper entitled Percutaneous Endoscopic Colostomy for Adults with Chronic Constipation, a retrospective case series of 12 patients. So Denise, could you provide us with a summary of what chronic treatment refractory constipation is?
Yes, of course. Thank you very much for inviting me for this podcast. In considering treatment of the chronic refractory constipation, at first we apply dietary changes and oral laxatives. Secondly, we use rectal enemas, which are then added to the treatment regimen. And the last conservative option we use here is retrograde lavage, which can be efficacious, but sometimes really time consuming, and often large volumes are needed, which results in considerable patient discomfort.
So what surgical procedures are currently out there to treat such patients, and do any of these procedures have any particular downsides at all?
So when all these conservative measures fail, surgical treatments are considered indeed, and options available are an appendicostomy, also called a Malone stoma, and an ileostomy with either a colonic exclusion or segmental or total colectomy, which actually seems to be the procedure of choice is a total colectomy with an ileostomy. Definite or temporary, which has some downsides as well. Complication rates are quite high, reported at rates of approximately 54%, with also a resurgery rate reported of 29%, which is quite high. And also we see that constipation persists in 4 to 15% of patients, sometimes needing further surgery. And an ileostomy also may lead to diarrhea, which seems to occur in about 10% of patients. And the other option I just called is the Malone stoma, which has also limitations, mostly occurring as stenosis, occlusion, or spontaneous closure of the appendicostomy, have been reported in 30% of cases. Also, It has a high success rate, around 70% or higher, but the complications are a problem. So it is considered an alternative therapy for patients with a high operation risk, but because the complications and the fact that patients need to cannulate the stoma themselves and often leakage occurs, makes it a less preferable option than the colectomy.
So that's really interesting. I think many of our listeners will be familiar with percutaneous endoscopic gastrostomies or PEGs. Can you tell me a little bit about percutaneous endoscopic colostomies?
Yes, of course. It's actually a technique we derived which was derived from the percutaneous endoscopic gastrostomies, and we actually use the same standard technique that's used in PEG placement. So the standard pull technique is used to place the percutaneous endoscopic colostomies as well. And we actually place the PEG tubes in the colon ascendens, and with that, the same technique, and then you can use the tube for antegrade colon lavage. Mostly patients need approximately 1 liter to irrigate their colon per day, and thereby it's less volume and less time consuming than the retrograde lavage, and seems quite a good option.
So why do you think this has been largely ignored in standard clinical practice to date?
Well, we believe it's due to several factors. First, and I think the most important factor is the fact that previous studies report relatively high rates of fecal peritonitis in approximately 10% of cases, which can be a very severe complication. And besides that, I think many of the gastroenterologists don't really know the technique or think it's difficult to apply. And other authors also reported this technique, but we believe.
What were the aims of your study?
Primary aim we had was to report our experience with the percutaneous endoscopic colostomy patients with chronic refractory constipation.
So that's really answered my next question in terms of what was your study population, but could you give me an idea of what kind of patients were included in this analysis?
Well, we included, we had only a small population of 12 patients, all with chronic refractory constipation. Most of the patients were female, like 75%, with a mean age of 65, ranging from 28 to 70 years, all failing conservative therapies previously.
So these were quite a challenging population by the sound of things. But what were your key results to come from your study?
Well, in our patient group, we found that PEC offered a safe alternative to surgical intervention. In all patients, we saw a moderate to good effect at short-term follow-up, and for the longer-term follow-up, we saw that approximately 50% of patients were having a good response to the PEC therapy. So actually, at short term, very good, and at the longer term, approximately 50% of patients had a good response.
What were the limitations of the study as you and your co-authors see it?
Well, at first, we think that the retrospective nature of the study and the small number of patients are, of course, a limitation of this study. Followed by the fact that it's retrospective, we hadn't got very well patient-reported outcome measures, so that made it difficult to to report outcomes well. Besides that, the exact etiology of the chronic constipation was not systematically investigated, so it was difficult to make a very good estimation of all the etiologies and thereby compare all the patients all together.
But nevertheless, I think your results are very interesting. And how do you see the potential implication of your results with day-to-day patient management in other centres?
We believe that in the patient with chronic refractory constipation, PEC could be a potentially worthwhile alternative and should be considered as an option in the treatment algorithm because it's minimally invasive, has shown in our study low complication rates, and should, in our opinion, be considered as an alternative option between the retrograde lavage and the surgery, actually.
So, what's in your view? How do your results take the field forward, and what are your views on the key knowledge gaps in managing these patients with refractory constipation?
Well, I guess our study provides a new insight on using the standard pull PEC technique, the same techniques used in gastrostomies, which we think can be applied by every gastroenterologist who's familiar with placing percutaneous gastrostomies. And besides that, we have used antibiotic gases after placement next to the intravenous antibiotic therapy. And we think that might have contributed to the low infectious complications and the fact that no fecal peritonitis occurred in our patients. However, it's, as we just spoke about, it's only a small group of patients, and thereby we think that the knowledge gaps are still should be fulfilled with more extended studies with larger patient groups and a more systematic investigation of all the patients' constipation etiologies, like we just discussed, to determine which patient might benefit from this form of treatment, because our study is I think too small to give any conclusions about that.
And I agree, and I think just in addition to that, a multi-centre study I think is now warranted. Yeah. So with that, I'd like to thank you and your co-authors for a really excellent and exciting paper, and also for assisting in this month's podcast, and also to our listeners for tuning in. I look forward to welcoming you to another instalment of the podcast next month.
Further information about this paper can be found on the journal website. We hope that you have enjoyed this podcast, and we look forward to welcoming you to next month's edition.